Hi, everyone. Tonight we have another subspecialty VMR, and this time with nephrology will be the focus. And for that, we have two very special guests, Dr. Tolwani and Dr. Noor. Dr. Tolwani, she's a senior scientist at the Nephrology Research and Training Center and a professor of medicine in the nephrology department at UAB. Thank you so much for coming, Dr. Tolwani.
Absolutely, happy to be here.
And we also have Dr. Noor. He's a nephrologist fellow at UAB, and he'll be discussing the case together with Dr. Tolwani. Thank you so much for accepting the invitation.
Oh yeah, thank you for having me. I'm glad to be here.
Just before diving into the case, I'd love if Dr. Tolwani and Dr. Noor could tell us the reasons why they chose nephrology as a subspecialty, and what do they do for fun outside of medicine. Why don't you go ahead first, Dr. Noor?
Yeah, so I'll just introduce myself. I'm Mustafa, that's my first name, and I go by that, and that's okay if you call me by that. I'm second year nephrology fellow. I'll be graduating hopefully within the next 1 month. My interest in nephrology came in actually in my first year of residency. Before residency, it was always that I wanted to do cardiology. But then one of my colleagues and seniors, he was very inspirational. The way his thinking, how methodical it was, and how clear his thinking process across different specialties, even though he was only interested in nephrology, and he ended up being a nephrologist. It was very simple, methodical, to the point. And even though you don't have to be the expert of every single disease, but it's how you approach things. And that's what fascinated me and made me critically think that maybe I should try to see what is behind it. And then I was fortunate to do some research work with him. And then that just led me down a path. And I was like, no, I'm not doing cardiology anymore. And then led me on the path to nephrology. So this is where I stand at. As far as things that I do outside work, I enjoy working out at the gym and just meeting up with friends, watching some TV, enjoying time with family, the usual stuff. But it's very important to have those to be able to switch off from work. And I'm glad that I have those things that I can turn towards outside of work.
Yeah, makes total sense. And I'm sure nephrology is a very happier place because of you. Dr. Tolwani, please go next.
Well, I actually was first interested in pulmonary critical care. And when I did my residency at UAB, nephrology was one of the few last services that still was allowed to take care of ICU patients without being a closed unit. And so I was very impressed with the breadth of knowledge they had in terms of taking care of not only all internal medicine aspects kicked up a notch, but their ability to take care of ICU patients. And so when I was approached about doing nephrology, I said, basically, sure, as long as you give me a critical care fellowship. And so I ended up doing a combined sort of fellowship here at UAB, and that opened a huge niche of ICU nephrology, and here I am. But I enjoy it because I love problem solving. I love being a detective and, like looking at trends, and so much things can be figured out by taking a step back and looking at the big picture and trends and figuring that out. So that's what excites me. As far as what I do for fun, I am a big and HIIT therapy and exercise enthusiast. I right now go to Orange Theory a lot. Have you anyone heard of Orange Theory?
I have.
You have. So it's like
Ashita. I go to Orange Theory all the time.
You go to Orange Theory, that's right. And I'm also an aerobics instructor, and before COVID was teaching Zumba and kickboxing. And so I love dance. I grew up doing classical Indian dance and performing. So those are my outlets and what I love doing.
Oh my God, this is amazing, Dr. Tolwani. Thank you so much for sharing that. Sounds really fun. We also have Shayna with us. Could you please introduce yourself?
Hello, everyone. I'm a 50 medical student from Germany, and I have such a big passion for internal medicine, and especially coming to nephrology. I love these glomerulonephritis cases so much. And another fun fact, I have a big pulmonary phobia, but CP Solvers helps me to end pulmophobia.
Hopefully today nephrophobia as well. Please go next, Gabriel.
Oh, hi, everyone. There's a construction nearby, so I cannot talk a lot. I'm so sorry.
No problem at all. Just to clarify for the audience, today I'm going to be presenting a case for Dr. Tolwani and Dr. Noor. Both will be discussing the case together. So could you please share the screen, Dr. Gabriel, and then we can start.
Yes, sure. Give me 1 minute. Yes.
Okay, awesome. So I'm gonna start a case and then ask for their inputs and other questions as well. So this is the chief concern here is abnormal labs. So this is a 60-year-old female. She reports that she was scheduled to undergo biopsy of the left lower lobe lung nodule and needed to obtain pre-op labs prior to the surgery. The patient was called on the phone by a nurse and told her to go directly to the ED, where she was found to have a creatinine of 6.4 with a baseline of 1.2 3 months prior. So my question here would be, how, as nephrologists, would you approach in terms of differential diagnosis and management elevated creatinine in an acute, subacute, and chronic setting? Why don't you go first, Dr. Tolwani?
Okay, so I can understand everyone being afraid of that creatinine of 6.45. So, initially you always think of common things being common. So my questions would be regarding, has anything changed in terms of volume status? Has this patient had issues with anything for me to think that there's a pre-renal type of picture from nausea, vomiting, diarrhea, infections, viral infections? All those things are very important. Any fevers recently? So one thing is to assess whether there's been something to change the volume status. The other big thing that comes in mind before we start looking at zebras is medications. So any new medications, what medications are you on? Have you all of a sudden started taking, I had a recent patient who was taking Advil, about 20 tablets a day. So, those are the first things to start off with. Other important information would be, of course, what other past medical history does she have? What other medical issues does she have? Is she having any problem urinating? Because you want to rule out symptoms of obstruction. So the first thing you're trying to get at before you get lab work is to get, the most important thing is detective work, was getting a history of anything to suggest a pre-renal, obstructive, or nephrotoxic cause. And that is, history is very pertinent in that. And then you can go from there.
Yeah, excellent breakdown, Dr. Tolwani. Dr. Noor, anything else to add? Oh, you're muted.
Sorry about that. Yeah, like I said, I agree with Dr. Tolwani, and basically the creatinine of 6 suddenly just worries us. But I think the most important thing is just to take a step back and kind of look at the big picture as to what is going on. Very, very important to know what is the underlying problems that the patient has, what are the medications that they are taking, and then to try to dissect and divide type of diseases within the kidney realm of things, and then to eliminate the common things before you end up going into the more rarer things. So the common things being anything pre-renal or any obstruction, easy thing, very quickly can be sorted out, and is very, very satisfying to be able to see that that is something you immediately fix.
Yeah, it makes total sense. Thank you. So moving on, the second aliquot on the review of systems, this patient describes no acute symptomology and denies fever, chills, shortness of breath, cough, abdominal pain, nausea, vomiting, dysuria, and increased frequency. Past medical history, this patient has hypothyroidism, hyperlipidemia, GERD, and GAD. No previous surgeries, no alcohol, tobacco, or illicit drug use. Medications she's on pravastatin, omeprazole, levothyroxine, and sertraline. And this patient is from Florida, and denies any recent travel history. Does this new piece of information change what you're thinking about this patient? Why don't you go next, Dr. Noor?
Sorry, based on this, at least it helps me think in the way that they do not have anything that is chronic that is ongoing that may affect the kidney directly. Certainly, they have a little bit of dyslipidemia, but no nephrotoxic medication that is present, no hypertensive concerns. They are not, at least apparently, they're not volume down. So next step that I would think is to look at the exam to assess if there's any hemodynamic instability that happened either pre or peri-procedure before I go forward to further labs.
Yeah. So Dr. Tolwani, why would you be curious about the physical exam of this patient?
So physical exam is, even though the patient may not give any history of nausea, vomiting, or symptoms of volume depletion, it may be that they have normally a blood pressure that runs higher, and now they have a blood pressure that runs lower than before. And so they have some normotensive ischemia, which they may not feel. So it's important to look at that. Patients have a lot of times new diagnoses of cirrhosis, heart failure. You would think they'd be more symptomatic, but not always. And the other thing with physical exam is to look for any sort of adenopathy, any sort of, those same things we talked about, obstruction. One other thing I want to add is, even though we have the medication history given here, some of the questions I have are, you always have to ask patients, have they had any herbal components, herbal teas, or any other herbal medications that are not typical? And so that would be the key issue at this time too, is don't ever forget that. But I agree, physical exam at this point would be important for not only hemodynamics, but a little bit better assessment of volume status. Is there rashes, anything, obstruction, suprapubic, fullness, etc., to rule out any of those things we already talked about.
Yeah, I really love how you mentioned the over-the-counter medications, because sometimes patients don't consider them medications, right? And they could be playing a role here. Thank you. So moving on to the third aliquot, the temperature was 39.9 Fahrenheit, heart rate 92, blood pressure 136/76, respiratory rate 18, and 97% on room air. This patient is in no apparent distress. HENT exam normal, regular rate rhythm with no murmurs, rubs, or gallops, lungs clear to auscultation, abdomen no tender, no distended, and the neurological exam were pretty much unremarkable. And this patient had edema up to, I guess, the knees on the physical exam. I'm going to give you a little bit of the labs as well. The white blood count was 8.7, the hemoglobin 11.5, the platelets 369, sodium 138, potassium 5, chloride 98, bicarb 20, BUN 44, and the creatinine 6.4, being 1.23 months prior, like we discussed before. And specific gravity was 1.010, ketones negative, leukocyte esterase negative, protein 2+, blood 2+, RBC more than 182, and white blood cells 7. So my questions would be, what would you be thinking about in terms of management and next steps for this patient? Why don't you go next, Dr. Noor?
Yeah, so one question that I would have is that, is this bilateral edema up to the knees something new, or has it been acute and chronic, or something chronic?
That was my first question too.
It seems like it's new. Yeah.
Okay. So just before going to the labs, just based on the physical exam, the presence of bilateral edema is very, raises alarms, if I would put it this way. So then the next question would come in is that, is this pitting or non-pitting?
Oh, I actually don't have this information.
Okay, so that kind of becomes important, because now my differential based on that, broadly speaking, is something, is it related to the heart? Or is this something related to the liver? Or is this something related to the kidneys? Just based going on basic physiology, where you remember that we talk about the capillary pressure, how much is the hydrostatic pressure, what is the oncotic pressure, and keeping that in mind, I would create the differential based on these three organ systems. And then going forward, considering that you mentioned in the cardiovascular exam that there's no rubs, there's no gallops, It does not 100% suggest so, but I'm presuming there's no JVD, so that makes the suspicion of a cardiovascular component lower. I'm presuming that there is no striation, no sequel that is associated with cirrhosis, which makes that suspicion a little lower, which leaves us to the renal system as one of the causes. And of course, you want to make sure that they don't have any suprapubic tenderness, which I'm presuming from the abdominal examination, it being normal, that it is unlikely. So that is just based on the physical exam. Should I talk about the labs or should?
Yeah, maybe Dr. Tolwani can talk a little bit about the lab and if she wants to add anything.
Yeah, I agree with everything that he said, that it's more leaning towards a concern for a renal association for the bilateral edema. Other things that I would ask on the review system is the patient had malaise, weight loss. You say no rashes, but any other systemic findings to suggest a systemic process. And it doesn't sound like that from your review systems. And so now if you look at the labs, you know, there's something very peculiar. We already know that the creatinine is elevated. And if you look at the urinalysis, you have a urinalysis that has protein in blood. And so this now suggests that this is a more nephritic pattern. And the biggest concern with that rapid increase in creatinine and also with that nephritic pattern for the urine is that this is a glomerulonephritis would be my biggest concern. And whether this may be associated to something to do with the lung nodule too. And so those are what I'm thinking currently. I'd like to get a few more labs that would help also determine how much involvement there is in the kidney. I don't know how many labs you have, but something that I would be interested in is quantifying the proteinuria, also looking at the albumin to see if there's a decrease in albumin. And those are some of the other labs that I would obtain at this time. I know that Mustafa and I agree that the next step also, which is really important, is looking at the urinalysis and sediment to see if there are evidence of red blood cell casts or something else that we see. And also for completion, we would need a kidney ultrasound to assess the sizes of the kidneys and if there's any anatomical issues. So that's where I'm leaning towards right now, or my thought process. And I'll let Mustafa add to that.
Yeah, and to add to Dr. Tolwani's point, I think so before, as we were talking about just on the history of presenting illness, we were concerned of something either is pre-renal or renal or post-renal. I think so we have kind of narrowed it down that this is something that is renal. So if we take a renal, what we mean by renal is something that is happening at the glomerular level of the system. And the question now comes in is that, is this a primary renal related, or is there a systemic involvement of any kind that may be causing damage to the kidneys? So it's one or the other. And considering the way the creatinine went up, it kind of hints towards a group of diseases which we categorize as rapidly progressive glomerulonephritis, of which we will be getting a series of labs, which Dr. Tolwani alluded to.
Do you have excellent breakdown? Do you have any suggestion on how we general, for example, people that are going to nephrology, how we can identify rapid progressive glomerulonephritis? When do we suspect that?
So I think so two big things, or the most important thing to know is what is the baseline creatinine. I think so that is the crux of it, knowing that what was it before any certain period of time, and then how rapidly did it increase. So example, 3 months ago, if it was normal, as you mentioned in the case as well, and suddenly when it went up, should raise alarms big time. I think so the second most important thing that comes in is in the urine analysis, which shows that there is blood in the urine, RBCs, and this is without having seen the sample under the microscope. It should again raise alarms that this is potentially coming as a nephritic pattern of kidney injury. And then of course, looking at the vitals, that the blood pressure is relatively on the higher side in a patient who is otherwise normotensive, should also raise alarms. So I think so rapidly increasing creatinine in an otherwise normal prior creatinine with blood in the urine should definitely raise alarms.
Excellent. Anything to add, Dr. Tolwani?
So if you are thinking this is a glomerulonephritis, and this is assuming again that we see dysmorphic red blood cells, red blood cell casts, essentially the urine is very suggestive of it, then the question is, how do we divide what type of GN there is based on the nephritic pattern? And there's so many different ways to look at this. The way I like to divide things into is basically RPGN, as Mustafa mentioned, a rapidly progressive glomerulonephritis, which occurs weeks to months with the onset of renal failure with a nephritic pattern. Usually these are associated with pulmonary findings, and these would be basically three things that cause an RPGN: anti-GBM disease, lupus. Lupus can cause anything, of course, and these are your ANCA vasculitides. And so that is the RPGNs and what I would be thinking about in that category. You also have something called acute GN, which is associated with more of complement-mediated GNs. This would be your infection-related GNs. We used to call it post-infectious glomerulonephritis, and it was mostly seen with streptococcal infections. But now we've realized any sort of infection, staph, bacteremia, endocarditis can cause an infection-related glomerulonephritis at the same time. And this would be mediated by low complements, C3 and C4. In this category too is what we call membranoproliferative GN, MPGN. That also is associated with low complements. And that is commonly, you all see this with hepatitis C or cryoglobulinemia, although there's nothing on physical exam to suggest some of that. But that would be the second bucket. So RPGN's one bucket, MPGN is another bucket. And then you have what's called, we call it this, although it's not really asymptomatic, but basically hematuria that's not associated with that much proteinuria. So asymptomatic hematuria. And in that bucket, the most common worldwide cause of that would be IgA nephropathy. And IgA nephropathy can present in some cases like 20, 30% with a picture like this that's more aggressive. Other things that fall into the asymptomatic hematuria category would be things like polycystic kidney disease, but then you will see that by ultrasound. Another cause of asymptomatic hematuria, and again, they call it asymptomatic, but it's really not truly asymptomatic, is Alport's disease would fall into this category. We usually think of thin basement membrane disease in this category, but thin basement membrane disease is a benign disorder which the creatinine would not be elevated. So those are some of the things I'm thinking about. If I were to think it's in this category, then IgA nephropathy would be high in my differential, because of all of those, probably that's more associated with elevation of the creatinine, or can be, and this is unrelated to the pulmonary findings. Then you also have basically, just plain asymptomatic proteinuria, which I'm not going to go into specifically since this patient has obviously red blood cells and red blood cell casts. So what would be helpful in trying to differentiate those buckets is also getting complement levels to start off with, because there's only 4 things you will see low complements levels in when it's associated with renal disease. Does anyone know? Who can name one? So lupus is one. Excellent. Yes. Lupus, infection-related GN used to be called post-infection. Excellent. MPGN, which I already told you, and there's one more totally unrelated to any of these categories. And I'll give you a clue. It's in situations where you may have a cardiac cath and you have shattering of emboli. So cholesterol emboli, you got it. So all of you got that. So that's really it. In the ANCA-mediated vasculitis, you don't see low complements. So having complements before you even get serology for ANCA-related vasculitis, ANA, is actually very helpful, and they come back very quickly. So those are the kind of things that are going through my mind right now. And at this point, I'll let Mustafa add to that? Because I'm sure he can.
Oh, I think you made it pretty comprehensive, Dr. Tolwani. But yeah, I also approach it in the exact same way, and basically looking at the um, I usually divide it into basically diseases which are complement mediated and are accelerated. So all of the disease processes that involve the complement direct or alternative pathway, they can cause rapid increase in creatinine. And then definitely those disease processes that not necessarily are going through the complement pathway, which includes ANCA vasculitis, anti-GBM, and IgA nephropathy, but they may have an accelerated pathway towards renal disease. So that's usually how I divide it.
Oh, amazing breakdown. Really excellent. Thank you. So moving on just a little bit further with the case, I think this is going to answer a lot of questions. So this patient had a normal C3 and C4. She also had a serum and a urine electrophoresis. No monoclonal protein was identified. Her ANA was negative. Double-stranded DNA was also negative.
Excellent.
And the serum free light chains demonstrate a normal kappa lambda ratio. So my question would be, what's going on now in your mind with this new piece of information? Why don't you go first, Dr. Tolwani?
Okay, from my perspective, it's unlikely, again, nothing's black and white in medicine, but it's unlikely to be any of those complement mediated disease processes that we talked about. Now, it's interesting that you did get a serum and urine immunoelectrophoresis, and I think that's perfectly fine to do. Most of the time, those are not associated with such extensive, red blood cells in the urine. But like I said, nothing's ever black and white in medicine, but I would be very skeptical if that was positive. So if we're looking at now the normal complements, your serum and urine immunoelectrophoresis negative, ANA negative, DNA negative, the missing pieces, even though the complements are normal, would be to checking a hepatitis C level. And finally, your ANCA vasculitides and anti-GBM. That's pretty much what is left. And I would argue with you that in some of these cases, a kidney biopsy. Mustafa, what do you think?
Yeah, I agree with Dr. Tolwani. I think so. The electrophoresis in this case, very rarely would I be concerned about it, especially if there's a nephritic pattern of kidney injury. You would associate this with a more chronic, prolonged, long-standing, slow renal dysfunction that would cause it. And so once we have ruled out that the complement mediated glomerulonephritis are ruled out, then primarily we are left with ANCA vasculitis, anti-GBM, and ANCA vasculitis and anti-GBM, and basically membranoproliferative, which would be your hepatitis panel.
So I do want to throw something else out that probably wasn't thought about, which we have to pay attention to. Essentially, the other thing that can present with hematuria and pyuria is something called chronic interstitial nephritis or acute interstitial nephritis. Okay, so that is something that's completely out of the glomerular spectrum of disease processes. And how would you differentiate that? Again, would be, looking at under the microscope. Typically in AIN, you would see white blood cell casts and you can see red blood cell casts, but most of the red cells will be monomorphic, not so much dysmorphic. And you'll have more of a clinical history of a medication exposure. So I just wanted to bring that out. And AIN is also associated with autoimmune disease. There'd be more symptoms associated with it that this patient does not have, but I wanted to make sure no one forgets that aspect of it.
And one more thing I would add also with Dr. Tolwani's point that I think so we didn't mention, but just to for the completeness, is that the platelets are also normal. So that is the other important thing that we want to make sure that there is no microangiopathies associated renal disease. So that makes it less suspicious compared to the other causes that we talked about. And along with that, because we have spoken about the complements being normal, We would also most likely after this in our differential, after ANCA vasculitis, would also be IgA nephropathy.
I agree.
And so we are heading towards a point where we probably will need a renal biopsy, which would help with the diagnosis and potentially even prognosis based on further discussion that we will have. And treatment, of course.
Excellent. It feels like I'm on a conference about glomerulonephritis. It's that good. Thank you. So moving on with this case, this patient, let's see. I actually have another question, which I think is important here. I think this is very controversial, but if you could give us in your input, when do we consider a renal biopsy?
So, from my perspective, I'll give you a couple scenarios where I think a renal biopsy is indicated. Anyone who you suspect that may have lupus nephritis is one indication to give a renal biopsy, since lupus nephritis can present with so many different manifestations and are treated differently, that even if ANA is positive, complements are low, you don't want to make assumptions. You need the pathology in that situation to determine what involvement there is, to see what drugs would be more responsive to. That's one. Another reason for a renal biopsy is if, let's say, all the things we just talked about are negative, there's no sure answer. Anytime there's uncertainty in knowing what the cause of the rise in creatinine is, whether they have a nephritic pattern or not, a renal biopsy is indicated. Now, some institutions will argue that if you have an ANCA-mediated procedure or a process, and ANCAs come back positive, that a renal biopsy is not necessarily needed and you can treat. For my purpose, I think that a renal biopsy would still be indicated in anybody who has such an elevated creatinine, because it's not determining only the cause or etiology of the kidney disease, but it's also prognosis, meaning how much interstitial fibrosis there is, how much scarring there is, how responsive they're going to be to treatment, because you don't want to unnecessarily give these patients large amount of immunosuppressive therapies if there's not much renal reserve left. So those in my mind would be the real indications for a kidney biopsy.
Amazing. Dr. Noor, in this case, would you consider a renal biopsy for this patient?
Oh, yes, absolutely. And so there are two major questions that you're asking. One is, what is the diagnosis? And the second thing is, you're linking with the diagnosis. So it's kind of connected to what the treatment is. So we know the treatment in general for vasculitises are immunosuppression. And they're not like 1 month of immunosuppression. We are talking about long-term immunosuppression, which begs the question is that, is it needed for the patient? Does the patient need to go through this extensive, large amount of treatment protocol for a long period of time? And so you want to be absolutely sure. So so that comes to the question of diagnosis. And at the same time, it comes to the question of fibrosis. I'll throw in two scenarios. If you have a patient, for example, with a creatinine of 6 or 7, and is 70 years old, and it turns out that the pathologist says, well, 80% of the kidney is already irreversibly damaged, which will put a completely different scenario to, it is a vasculitis, but your approach towards it would change. Versus the question comes in and, well, there's only 10 to 15% damage to the kidney, and there's a lot of extensive inflammation that is going on. And that gives you a hint that there is a potential of salvaging the kidney, and you want to achieve that. So those are the two approaches, is the diagnosis and the prognosis, looking at that. And then the third component in the background, are there any absolute contraindications which would we would say, no, we are not going to do a biopsy. Those would be the three things.
Yeah, incredible. Thank you. Yeah, it's so controversial, right? It's good to know the nephrologist input on that. So moving on.
And the other way I would also put it in is, there's no harm in always talking about it. A lot of times we sometimes think that, I would say we do not strongly feel that a patient should have a biopsy, but sometimes we talk to the primary team, the ICU team, and they bring us ideas or thought processes that may change our minds as well, and say that, okay, maybe actually a biopsy may be helpful. And so it kind of changes our perspective as well. So I think so talking with one another across different specialties is also very helpful, or whoever is involved in the care as well.
Yeah, and I think for the most part, anyone who would see this type of elevation in creatinine in a nephritic picture like this would probably agree for a kidney biopsy. But there are contraindications. I mean, for instance, not only contraindications, the patient has, coagulopathy and low platelets, but if the patient's in the intensive care unit and cannot be lying prone to get a kidney biopsy done, or too short a breath to get a biopsy done, or too unstable, those are some of the real issues. A lot of times I'm in the ICU and we're asked all the time, well, we need a kidney biopsy. And I said, that's great, but the patient's not stable enough or safe enough to get one. I want one too. So that's a big consideration, is the logistics and the practicality of it. So.
Yeah, thank you for bringing your perspective. It's really, really elucidating. So this patient actually had a renal biopsy, and a light microscopy revealed severe concentric glomerulonephritis, 100% crescent. So we're talking about that this biopsy is consistent with diffuse progressive glomerulonephritis. And I would love if you could tell us a little bit about the possible etiologies and what could be the next steps in terms of management for these patients.
So should I go?
Yeah, go ahead.
Okay. Sorry about that. So yeah, I think so. I would need a little bit more information based on the renal biopsy. One of the most important thing is in the differential currently, when we spoke about the vasculitis, is one is ANCA related or anti-GBM, and the third one in the differential is IgA nephropathy associated crescentic glomerulonephritis. So just looking at this statement, what basically it means is that there's immense inflammation going on in the glomerulus to the point that it has damaged the architectural structure of the glomerulus, causing it to form what is called a crescent. And so what I would want to know is, are there any immune complex deposition that is ongoing within the glomerulus, which would help further with the differential diagnosis? Because ANCA serologies, we know it takes a little longer than the usual. So that would be the next step that I would want to find out based on the light microscopy, electron microscopy, and then immunofluorescence if there's any deposition. So it's never one alone that helps us. Light microscopy showing crescentic GN means that there's a very accelerated, rapid damage to the kidney. And that's just like a wording, but I would want to know what is the next thing that may have caused this. And so we have to take all three components of a biopsy to help solving the problem.
I agree. So you're trying to distinguish, like he said, crescentic GN could be seen with a lot of those vasculitides, even IgA nephropathy, but they're all may not be treated the same way. And so that's where the immunofluorescence really helps you pattern-wise. For instance, anti-GBM, what do you think that if you had immunofluorescence in the EMs, where do you think it's going to light up? Anti-GBM, right? The GBM membrane, exactly. What about if you have an ANCA? How many of you heard the term posse-immune? All heard of that? What does posse-immune mean? Is that if you do immunofluorescence for an ANCA-related vasculitis, is that there is no immunodeposits because it is a circulating antibody antigen-mediated complex. So you won't see any staining immunofluorescence for antibodies and complements, et cetera. And then if you have lupus, which would all present like a crescentic GN, guess what you see in the glomerulus? How many of you play poker? Is it poker that has full house? Staining? Okay, I may be really bad at my cards here. But basically that means that you will see staining immunofluorescence for everything, all immunoglobulins, all the complements. We call that full house staining. And it's very important to distinguish that. If it's IgA nephropathy mediated, guess what you're going to see in the immunofluorescence? IgA deposits. So that's what he means. We need more information of the exact etiology so we can treat it more effectively, because not all of them are treated the same way.
Yeah, I'm purposefully hiding this information.
Of course.
So
we wouldn't have it any other way.
Here we have many medical students like myself, and I would love to know, what does eccentric mean to you in terms of pathophysiology and prognosis for this patient?
Mustafa, you want to answer that?
Yeah, sure. So essentially, if we break it down, a structure of the glomerulus, we have something called the mesangium, which is basically the structure in the middle that kind of holds the scaffolding of the whole glomerulus.
The
And
glue.
then, of course, the glue, yeah. And you have all the blood vessels that are ongoing inside it. And then, of course, you have the epithelial lining and the endothelial lining. And then what you have is the basement membrane through which all of the process of filtration and everything happens. Essentially, when you have damage to the basement membrane lining, you have extravasation of inflammatory cells that causes extensive, basically just wreaks havoc. And once it does that, it causes extensive inflammatory response, which causes the structure of the glomerulus to be damaged and cause what appears to be a crescent shape. Or it appears like a crescent, and essentially it's just inflammatory cells chewing up into the scaffolding and into the various structures of the glomerulus. As simple as that.
Mm-hmm. It's composed of macrophages, of fibroblasts, and T cells. So it's all those inflammatory cells that form a thick kind of rind around the glomerulus that looks like a crescent. But you can also see fibroid necrosis in those crescents, which is a very, very active disease pattern. But it's all crescentic GNs have that typical finding.
And if you see a crescentic, it's always bad, or there's
Yes.
like a lot.
Yes.
Okay.
Prognosis is your kidneys are going to die very fast if not treated. Absolutely.
Okay, thank you. Yeah, that's a question that I had. So let's see. So for this patient, the immunofluorescence actually showed linear deposition of IgG along the glomerular basement membrane, consistent with Goodpasture disease. This patient was treated with daily plasmapheresis, methylprednisolone, cyclophosphamide, and hemodialysis. She underwent a chest CT, and lung nodule was no longer present. So I feel like a question here would be, as generalists, what should we know about Goodpasture disease? And what would be the 3 main takeaways from this case? Please go next, Dr. Tolwani.
So in general, I'm sorry, tell me what the first part of that question is.
Like, as a generalist, what should we know about a Goodpasture disease?
So basically, you can have pulmonary renal involvement. There's some association apparently with hydrocarbons. Typically, more commonly, not only do you see a nephritic pattern in the kidney, but pulmonary hemorrhage, probably more than pulmonary nodules. But the biggest issue that the generalist needs to recognize is that this is something that needs to be treated pretty aggressively. And since it is mediated by an antibody, that it requires not only cytotoxic therapy like you recommended with steroids, immunosuppressives, but plasmapheresis is very, very essential. And I think it's recognizing more than anything for the generalist is that someone has an abnormal kidney findings with a nephritic picture and an abnormal lung finding, and probably to call a subspecialist like nephrology to look at the urine and to try to make the association.
Yeah, thank you. Dr. Noor, looking at this case, what would you think would be the 3 main takeaways from that?
I think so. The main takeaway would be we all nephrologists love to do detective work. And like Dr. Tolwani said, and she's an amazing mentor for me as well, looking at the trends. Most important thing, knowing what the baseline creatinine is and how quickly did it go up. Looking, of course, in the big clinical picture, the medications, any acute things that, or rather I should say the common things being common. And in the physical exam, what new finding have you found? And in this case, for example, in the association with edema, which organ system is involved? And once you have seen that, how can you eliminate them? And then the final thing is, if you have narrowed it down to the kidneys, is to understand that if there's an elevation in creatinine with blood in the urine, I think so it's very important to either talk to the nephrologist, or I would say you don't have to be a nephrologist to be able to see the urine under the microscope, but certainly it helps to learn in the process. but certainly to look at it and say that, yes, there is something that is actively involved in the kidney that can be potentially irreversible and can extensively damage the kidney. So we have to intervene quickly. And based on that alone, order tests or labs associated with it. So recognizing elevated creatinine in the setting of blood in the urine and ruling out other causes based on history and physical examination or testing if needed.
Absolutely. Also to recognize like anti-GBM disease can be, as you get older, renal limited. So it doesn't always can have pulmonary findings. It's usually the younger ages that have pulmonary hemorrhage. And a lot of times we'll see just renal limited disease. And the only way to know is by biopsy and getting the lab work.
Incredible, incredible. Actually, Dr. Tolwani, I was going to share this girl that with Pasteur disease in less than 30 years old, most likely to be male, and to manifest both pulmonary and renal manifestations, and older than 50 years old, more likely to be female and to have isolated glomerulonephritis. Thank you so much. Such an educational session, really, really. Thank you.
That's
Thank
a
you,
really
Dr.
good
Noor.
case. Did you guys get
Did
you guys get anti-GBM levels?
It was not on the. This is a case from a friend of mine, but it was not like described.
Yeah,
but
I'm
I
just
can
curious.
tell you later. I can tell you later. Thank you, Dr. Tolwani. Anything else to share, Dr. Tolwani, Dr. Noor?
No, I think so. This is a very, very good case.
Yes, absolutely. Be afraid of increased creatinine. There you go. Take it seriously.
May take away from the session. Thank you so much. And now, just to finish the session, could you please, Shima, finish with the teaching points?
So hello everyone, what a great case. So thank you for the great discussion. So coming to the teaching point, so we had a high creatinine, and as it was common things being common, rule out a pre-renal disease or post-renal disease, looking whether we have any obstruction, and also ask if we have any recent new medications to rule out a nephrotoxic issue. And also consider whether there's any systematic problem, like if there's any weight loss, malaise, and in terms of a physical examination, to look at the vitals to see whether there's any hemodynamic problem. Also, is there any rash, suprapubic tenderness? And then we were talking about edema, prioritize it to the kidney, but also consider like the heart and the liver, which were normal here. And then we had protein and blood in the urine. So this is considered as a nephritic pattern. And we also had a rapid increase of creatinine, which was a concern for a glomerulonephritis. And at the beginning, we were also looking whether there's any possible association with a pulmonary nodule. And also, for the rapid rise of creatinine during a short time, consider a rapid progressive glomerulonephritis. And the most important thing is to look at the baseline creatinine. So if you have a rapid increase, and also if we have a nephritic pattern, and also look for the blood pressure, which is usually high, but it can also be normotensive. And there are like these three categories to divide for rapid progressive glomerulonephritis. The first is Antigbm. The second one is usually immune complex mediated, like in lupus. And the third one, the ANCA associated, which show a post-immune pattern. And then we were also talking about MPGN, which is typically showing up with low complement and is associated with Hep C or cryoglobulinemia. And if we have asymptomatic hematuria, consider IgA nephropathy, polycystic kidney disease, Alport syndrome, or thin basement disease. And if we have low complement, consider lupus, any post-infectious stay, MPGN, cryoglobulinemia, and cholesterol emboli. And for normal complement, think of ANCA, Antigbm, MPGN, and IgA. And then we were talking about hematuria together with pyuria, consider interstitial nephritis, and we're talking about acute interstitial nephritis, where we have white blood cast, and also monomorphic red blood cells, in contrast to glomerulonephritis, where we have these dysmorphic red blood cells. And also consider that there could be any medication exposure, which is typical for this interstitial nephritis. And also the platelets are normal, so we don't have any microangiopathic issue. And also what I learned new is for the renal biopsy. So it's not only to rule out talk about the etiology, it's also relevant for the prognosis, like to see whether we have to treat this person very aggressive with immunosuppressants. And then if the light microscopy shows a crescentic glomerulonephritis, which we always say half moon here in my country to this half moon pattern. And then the key question is look for any immune complex deposition, and in the immunofluorescence staining, is there any post-immune pattern? So post-immune means we don't see any immunofluorescence staining, which is an anchor. And if we have a full house staining, consider lupus. And what was also told for pathology, the crescent consists of fibrotic cells, inflammatory cells. And then coming to the conclusion of this case, it was a Goodpasture syndrome. So we have this nephritic pattern. It is associated with pulmonary hemorrhage, and we need a very aggressive treatment. So only the cytotoxic medication isn't sufficient. We also need plasmapheresis, and it's also antibody mediated. I think it was, as I write, antibodies against collagen, which are also in the kidney and also in the lung. That's why we have this. Yeah. Thank you very much.
Excellent job. You just finished a whole mini fellowship in GN diseases and just so in the last 5 minutes in your summary. I think you're ready to be an expert nephrologist.
Thank you.
That was everything you said was taken months and weeks for other people to learn. So very nicely put it together. You're all experts now. No, but we had a lot of fun. Thank you guys. That's a great case. And hope you all have a very nice the rest of your day. Some of you early morning.
Yeah, thank you so much, Dr. Tolwani and Dr. Noor. I'm sure many people will be thinking about going to nephrology.
Come on down. We love being detectives.
Have a good night, everyone. Thank you.
All right. Thank you very much. Have a good one.
Thank you.